Welcome, everyone, and thank you for joining us today. I'm Emily Burley with Boston University's Federal Relations Office, supporting today's host, the Boston University Center for Emerging Infectious Diseases Policy and Research. Next slide, please. We have a top-notch panel on hand to provide you with the information that you need to develop effective policies to promote equitable vaccine access worldwide. Please feel free to ask questions at any time in the Q&A box at the bottom of your screen, and we will do our best to answer them in the Q&A portion following our presentations. Next slide, please. A recording of today's briefing, as well as the slide presentations, will be available at the Boston University Federal Relations website at the link you see on your screen. Dr. Amy Maxman from Nature will be our moderator for today. But before I turn it over to her, we are honored to have remarks from Representative Lois Frankel of Florida's 21st Congressional District and a distinguished BU alumna.
Hello, everybody. I'm Lois Frankel, member of Congress from South Florida and a proud graduate of Boston University. And I'm so happy to be here with Dr. Nahid Badalia, one of the world's leading infectious disease specialists and who's become a member of our household as one of the most trusted TV doctors. I call her the real Meredith Grey. Anyway, we're all looking forward to hear what she has to say tonight. And if we've learned anything in this past year, we know we still have a lot of work to do in preventing and responding to pandemics. And that's why I'm thrilled that the CEID is continuing to make progress in this area. The pandemic has taught us truly how connected we are in this planet. If pandemics are global, our response to them also has to be. And so, as a member of the State Foreign Operations Subcommittee of the House Appropriations Committee, and also the Health and Human Services Committee, I want to tell you that we have put substantial resources into responding to the pandemic throughout the world, including sending millions of vaccines especially to undeveloped nations. So we believe it's not only the moral thing to do, it's the right thing strategically to do for our own health. A disease that began in Wuhan, China, quickly destroyed lives and livelihoods in my hometown in West Palm Beach, Florida, and many of your hometowns too. So because at the end of the day, diseases like COVID-19 don't care about borders. This is a global fight that we have to care about. So thank you to Dr. Badalia and BU for addressing this global challenge. I know this is going to be an interesting format, and I'm so glad there's important work being done at my alma mater, Boston University. Everybody, enjoy the evening.
Great, so let me just get started. Thanks so much for that introduction. So I'm Amy Maxman, I'm a senior reporter at Nature. I'm honored to talk with you about what I really think is the most pressing issue today, and it's getting COVID vaccines around the world. Today, you're going to hear perspectives on this issue from distinguished panelists. You know, something to keep in mind during these talks is where we're headed as COVID continues. What will the world look like at the end of this year? What's it going to look like next year if the United States and other rich countries don't even push vaccine equity up further on the list of priorities? COVID's very high in India right now, where 80% of the population lacks vaccines. Just south of our border in Mexico, around 85% of people are unvaccinated. And COVID is rapidly rising in sub-Saharan Africa, where there's actually almost no vaccines at all. So not only does that mean that there's going to be many, many more preventable deaths this year, but letting COVID run unabated causes long-term problems. You'll hear about some of them today. It's crushing health systems, it drives people into poverty, and it drives insecurity. It's also harming the global economy because we're all connected. So in places without vaccines, it's just going to get worse and worse. Plus, there's the threat of a new variant arising that's more deadly or that resists the vaccines we have today. That grows literally more likely every single day. In the first months of 2020, the US failed to respond quickly to SARS-CoV-2 as it spread around the world. And I fear that we're doing the same thing right now. It's like watching a slow-moving train wreck while we let this virus spread and evolve, despite having developed these remarkable scientific tools to stop it. So I'm honored to present today 3 speakers who are going to give you important details. The first speaker is going to be Dr. Nahid Bhadelia, an infectious disease doctor and founding director of Boston University's Center for Emerging Infectious Diseases Policy and Research. Then we're going to hear from Josh Michaud, who's the Associate Director of Global Health Policy at the Kaiser Family Foundation. And then finally, Musoka Fala, who's the president of Refuge Place International. He's also the former head of Liberia's Public Health Institute, and he helped lead the Ebola response during one of the world's largest outbreaks. So without further ado, let me turn things over to Dr. Nahid Bhadelia.
Thank you so much, Amy. And I want to start by thanking Congresswoman Frankel for her really kind remarks. Let me see if I can put this into a slideshow. I want to welcome everybody. And as both Amy, Emily, and Congresswoman Frankel have said, this is important to us because our collective destinies of how we make our way out of this pandemic are tied. And one of the reasons that this center was founded, as you can see, is to build the type of resilience that we need to not just address the current threat of the COVID pandemic, but also future threats. Because what we're noticing is that as we change the world around us, the threat from emerging infectious diseases grows. And as we are more connected, that threat is even more interconnected. And as we move forward, I think the work that we're going to be doing as a center and have been doing is through interdisciplinary, transdisciplinary research, through capacity strengthening, through partners such as Dr. Fala in Liberia and in other countries, and through advocacy, through the activities that we're doing here. You can get more information about our center at the website that I provided here. I want to start by putting this up. I think that if there's anything that this graph should tell you is that we are already witnessing both a moral failure of the pandemic response globally. I think yesterday, Dr. Tedros, the WHO Director General, talked about how COVID-19 pandemic as a test, and the world is failing. And it's failing because what you see here, the light, very light areas, are reflecting areas that are severely under-vaccinated. And it's a test because their under-vaccination is tied to their long-term recovery, their short-term impact through the pandemic, but as well as our long-term recovery as well. I wanted to take the time today. I think Josh is going to go into the numbers in where we are in terms of distribution of the vaccines. I wanted to take a step back and talk about different numbers, about what the COVID-19 pandemic has already done and what it will continue to do. Already, you're looking at over 4 million, and you're seeing over 115,000 healthcare workers who have passed away worldwide. And that's a big deal in areas where you might see 1 or 2 doctors per 100,000 of population. You're seeing the prediction is that this last year has left almost 95 million people who might be pushed into extreme poverty, additional 95 million who might be pushed into extreme poverty. You're seeing food insecurity, about 130 million who are being pushed into brink of starvation. Not only is it the fact that COVID-19 pandemic is affecting those who have the disease, who are admitted, but it's also affecting other routine functions of healthcare systems. There's a recent WHO report that says that there's the delay to routine immunizations that has extended to about 23 million people worldwide. What that leads to is secondary outbreaks. When you drop the amount of immunity in a community from measles, for example, you're going to start to see measles outbreaks. And we've seen that in lesser degree in the aftermath of other outbreaks and epidemics, such as the 2013-2016 Ebola virus disease epidemic in West Africa. And you're seeing impacts on childhood education, about 1.54 billion children out of school, a whole generation affected. And the longer communities that are unvaccinated have to go through lockdowns, through non-pharmaceutical interventions to slow the spread of disease, the longer that impact, social impact is going to be. But it's also a global impact on our economies. The longer there are, societies are overwhelmed from acute surges of infections, you're going to see factories close down, you're going to see production close down, you're going to see trade be affected. And in fact, the International Chamber of Commerce has predicted that you might see about $9 trillion decrease in losses in terms of global world economy. And it's beyond that. And I kind of want to flesh this out because I think that this may be obvious to some of you, but I want to flesh this out because the impact, the magnitude of this pandemic, we've been dealing with our own surges and we haven't turned our eyes to how bad things are and are going to continue to be globally for a while. Not only are you seeing ongoing COVID-19 surges that are increasing in areas that we thought initially may have escaped the worst of this. You're seeing this in parts of Africa and Latin America and Asia, where countries are starting to get overwhelmed again with a more transmissible variant, the Delta variant. You're seeing healthcare worker illnesses and overall case fatalities increase. Whether you die of a disease is not just a function of a patient and their biology. It's not just a function of the virus. It is also a function of the healthcare systems. And Dr. Fallah is going to talk about that a little bit. But the more overwhelmed healthcare systems are, the worse the case fatality from a particular disease. And then because health systems are overwhelmed, you're not able to meet other needs. And so you're likely to see impact on everything from non-communicable diseases such as heart disease and strokes to other infectious diseases. And not only that, but there is no law that says that just because there's one pandemic, there may not be another outbreak or epidemic that occurs. In fact, if anything, it makes it more likely. If you have overwhelmed healthcare systems and surveillance systems, you create a vulnerability. And I see that happening over the next few years, that may mean that we miss the next threat that's coming down the pipe because of that. And then there is the ongoing psychosocial impact of just living through this tragedy globally. We're also going to risk evolution of new variants. I'm going to talk about that in a second. And then impact on women's empowerment, health, and education indicators. You're going to see an impact on environmental indicators as communities are pushed into extreme poverty and have to survive on that interface between the human and animal boundary. And then you're going to see, because of that overwhelming impact on local economies, political and potential social instability. And this is where I think it becomes even more important. On the right, what you see is a study from IMF from 2020 that showed that in the aftermath of most epidemics and outbreaks in those countries, income inequality increases. It's not just a global loss of economy. In those communities, the poor only get poorer. And then here you see those numbers again from in a bit more granular detail from the International Chamber of Congress. In the US, the assessment is that if we cannot get equitable distribution of vaccines globally, we could see an impact of about 45 billion to 1.38 trillion in US to our country alone. I want to talk also about the threat of new variants. So new infections, every new infection, the way the viral evolution occurs is that every time it replicates, there's a chance for mutations. And the more infections there are, the more mutations may arise. That's not to say that every mutation that occurs necessarily offers an advantage to the virus, but those viruses that end up with mutations that allow them to transmit more easily or to bypass the immune system or vaccines or medical treatments are more likely to cause more cases. What we know, the science currently says, is that if we continue to see evolution of this virus, you're going to continue to see the rise of new variants. Now, because the vaccines that we have currently offer broad-based immune protection, not just antibodies, but also T-cell response and long-term memory, you won't get to a point where the vaccines are completely ineffective, at least in the medium term. But you may see decreasing efficacy of vaccines over time. The last part of this is that there are efforts to keep on your radar to create. Right now, the vaccines are created against the part of the virus that the virus uses to enter the human cells, the spike protein. There's conversations and investments from CEPI and other organizations about research that can create vaccines that can be a bit more durable, because they look to target those parts of the virus that don't mutate as much, that are not under the same kind of pressure from evolution. And that might be a lot more effective, not just against all variants of COVID-19, of SARS-CoV-2, but actually a whole bunch of beta coronaviruses, which are epidemic-prone viruses. Very briefly, to introduce COVAX, which Josh was going to talk about, the goal of COVAX, and it was created partly because of the lessons from H1N1 and the fact that it took, months to a year to try to get, or longer, to try to get H1N1 vaccines out to the rest of the world. The point was to provide incentives and investments to manufacturers and to create a collective purchasing power where self-financing countries can dedicate or commit to purchasing a certain number of vaccines through COVAX, and that benefit is then used to utilize, purchase, and contribute to vaccines to those areas of the world that are lower middle income and do not have the same kind of purchasing power. The challenges, though, are first and foremost, I'll start with a third one, was that when this happened, what COVAX found was, on the open market, they were competing with other high-income countries, and those who were able to offer a better price and take over most of the production or purchase most of the produced doses that were out there. They also found that there's a lack of enough funding for COVAX itself. The money is not just for the purchase of the vaccines, but the cost it takes to distribute that, to set up the supply chains, to effectively get the vaccines to the last mile. And where there was capacity potentially, like in Serum Institute of India and elsewhere, where there were a capacity to make vaccines in secondary sites or raw materials, there was export control on raw materials that limited the number of vaccines that could be produced. Some of that has been lifted, and so you're starting to see that. The other part that kind of limited this was that India, which was, Serum Institute of India was to produce both the Oxford adenovirus vaccine, but it was also supposed to create its own version of it, was affected by their own local surges, which delayed the production of the vaccines that are going to the rest of the world. The other two aspects to just keep in mind are just the last mile, the cold chain, particularly for mRNAs that require, in some cases, ultra cold freezer storage, and then vaccine hesitancy. Even before the COVID-19 pandemic, WHO listed vaccine hesitancy as a top 10 global health problem that's facing the world. Very quickly, I think that the goal as we come out of this is to recognize, and Josh's numbers will sort of display this, is that we can patch things together in the medium and short term. But the long-term map and the long-term aspirations have to be for global manufacturing capacity for vaccines. And the roadmap to that is, yes, people have been talking about the TRIPS waiver and the intellectual property rights waiver, but that's not enough. But because the actual production of vaccines requires a technical know-how transfer. So the mechanism of how you share that is starting to be set up by WHO and other organizations, but companies have to want to, aside from giving the waiver, have to want to share that expertise. There's the need to create that physical infrastructure in places where this capacity does not exist, to set up those factors, to set up the physical infrastructure, but also to train local expertise and to promote that local expertise. And then to work on the supply chain for mRNA vaccines, for example, the mRNA caps or other aspects of the way the vaccine's put up get produced by single companies. And those pieces are also under IP rights limitations as well. And so working on just setting up those things, but not working on expanding on the raw materials, it would be an issue. The other things to think about are manufacturing and health regulatory capacity. WHO had a study that said 30% of national regulatory bodies actually have the capacity to manufacture and potentially distribute safe vaccines. So working on regulatory capacity in low and middle income countries is going to be important, as will the health surveillance capacity once vaccines are produced, to ensure that there is oversight similar to what we have here with the CDC's vaccine adverse effects or VAERS system. What can we do today? Very rightly ending with this, Pfizer today announced that they will help South Africa set up what is called the finish and fill facilities, where they're able to send most of the pre-made elements and allow the local manufacturing to finish that production and to distribute. And they're potentially in that plant have predicted about 100 million production per year. Unfortunately, it's unclear when that's going to be able to be set up, and even whether it's that capacity or the redistribution of surplus that's currently been contributed or dedicated to the rest of the world, the timeline does not match the need. We do not have enough vaccines now when it makes a difference. Most of the bilateral agreements are actually not committed until 2022. In the short term, aside from redistributing surplus, we need to lift restrictions on raw material exports even more, and we need to continue working on long-term capacity building. What is the surplus? How much vaccine do we have to give? These numbers might be slightly lower than what Brookings predicted, because our own production projection has been slightly lower, but these are big numbers. By the end of the year, the US might have almost 1 billion doses of surplus vaccine, and that's taking account for having vaccinated children and adults and keeping the surplus in-house for potential needs for boosters and other things. So I'll end there and pass it back to Amy and then Josh. Thank you.
Hi, I think I'll just have Josh Michaud. Why don't you take it from there? And I think we'll take questions afterwards. Maybe that's the smoothest way to do things.
Sure, that's great. Thanks, Amy, and thanks, Nahid. Let me provide you with my slides here, and there we go. Hope we can see that. So yeah, my name is Josh Michaud, and I'm with KFF, the Kaiser Family Foundation. And if you don't already know, KFF is a private, independent, nonpartisan data research, analysis, information around healthcare policy issues of interest to the US and globally. And I work for part of the foundation which focuses on global health issues. I come at this issue as an infectious disease epidemiologist by background, but I've been with Kaiser now for 10 years, focused on the policy aspects, particularly of how the US government engages on global health. And like many people, for the past 18 months or so, been focused very heavily on COVID. So what I hope to do today was to really provide a snapshot of where we stand globally in terms of vaccine access, in terms of the progress made towards administration of vaccines globally. Luckily, KFF came out with an analysis just released this morning, looking at this very issue, which I'll be referencing during this talk. So by the end of this, I hope you have a good sense of the scale of the gap between vaccine haves and have-nots globally. So to begin with, let's talk about vaccine production. And Nahid mentioned, the need to scale up production. If we look at the projections as best we can right now in terms of global vaccine production, I mean, one thing we have to recognize that it is truly impressive that in the space of about a year, countries have been able to collectively create multiple effective COVID-19 vaccines. Perhaps in some countries we take this for granted, but it's a blessing that we have these vaccines in the first place, and they are as effective as they are. And the global picture would look much worse than it does in the absence of vaccines. So as far as where we are in producing these wonderful tools, this is a chart from the analytics company Airfinity, which shows how many doses of vaccines are expected to be produced this year. And each of these bars refers to production expected at the end of each month. You can see here we are getting close to the end of July, where production might total 4 billion doses globally. And by the end of the year, there might be as many as 9 to 11 billion doses produced globally. And these are spread out across many different vaccines. And so there are the vaccines that we're very familiar here in the US, the Pfizer vaccine, Moderna, J&J. And then there are others which are familiar globally, including the AstraZeneca Oxford vaccine and the Chinese vaccines, Sinopharm and Sinovac. Those set of vaccines make up the bulk of the production both now and going forward. So all told, 10 to 11 billion doses might be produced. But of course, these are projections and they depend on a lot of things going right. And I think there's been some optimistic early projections which haven't panned out. So we'll see how things go, but we can hope that we do get more production than this and hopefully get as much as this. But what we'll see is that while we might have what seems like a large number of vaccines produced, the distribution of these vaccines is highly unequal. One of the reasons, which was highlighted by Nahid already, was the fact that many of the vaccine doses that are going to be available this year are already locked up in contracts. So they've been spoken for with contracts, especially high-income country purchases on advance orders for the production for the rest of the year. A big portion of the supply, as you can see from this chart, has already been spoken for. So this graphic comes from the New York Times, drawn from the Airfinity data as well, and projects that of the almost $11 billion doses that are produced this year, 9.9 billion have already been spoken for. And according to Duke University, it's really the high-income countries and upper middle-income countries to a great extent, which have purchased well over half of these vaccines. So while high-income countries comprise about 15% of the global population, currently high-income countries have purchased over 40% of the vaccine production globally. Turning to distribution and vaccination progress, here we have data from our World in Data showing how overall vaccinations have progressed. So remember, we had an estimate of about 4 billion doses produced by the end of July. Well, much of that supply is being administered around the world. According to this, 3.5 billion doses of COVID vaccines have administered so far around the world. And this is across all the vaccines for which we have information. But it's quite clear that the overall progress in vaccination is one picture, but when you start to look at the distribution, that it's highly unequal across countries, across regions, and across income levels. So in our analysis that we released this morning, we pulled data on country level vaccinations and looked at trends by income group and by region. And I want to give credit to the rest of the team at KFF that worked on this as well, including Anna Rao, Adam Wexler, and Jen Cates. The findings here, I think, speak for themselves. While over 50% of the people living in high-income countries have received at least one dose of a COVID-19 vaccine, in low-income countries, that number is 1%. On the chart on the right, you can see that there is a green line, which is almost indistinguishable from the horizontal axis, and that is the progress on vaccination in low-income countries. And that is the crux of the challenge that just represents the scale of the income of the vaccination access gap that we're talking about. So in fact, there's just 3 countries, that China, India, and the United States, which account for 57%, so more than half of the vaccine doses administered globally at this point to date. So one note about this chart, you might note there's a little jump there. That's an artifact of the data coming out of China. China reported all at once a number of people vaccinated in June, and so the numbers reflect that data reporting issue. So one reflection of this restricted access to vaccines among low-income countries is that in these countries, even the highest priority groups have not been vaccinated at this point. So this chart comes from Philip Schelikins, who works at the World Bank. He analyzed vaccination rates in countries by income group among healthcare workers and seniors, which we across the world agree universally should be the first in line to receive a vaccine. But we can see that in low-income countries, far less than half of healthcare workers and seniors, the highest risk groups that are most in need of vaccination, have been reached with vaccines. And if you break this down by different countries, even that distribution can range from very, very low numbers, almost 0% of this high risk group that's been reached. So as Nahid mentioned in her comments, now that we're seeing the Delta variant increase the number of cases across many regions, and particularly in Africa and parts of Asia, the lack of access among the highest priority populations is a very big concern. It speaks to the immediate need for vaccination, not just the general population, but for the highest risk populations. So if we look at the pace of vaccinations, and if we extend out the current pace of vaccinations, we can see that the inequalities are likely to grow. Particularly in low-income countries, the globally agreed upon targets by the World Health Organization, World Bank, and others of trying to reach 40% of populations by the end of 2021 and 60% of populations by the middle of 2022 are going to be very, very difficult to reach at current pace for low-income countries. So high-income countries and upper middle-income countries are on track to meet these goals. And lower middle-income countries are close to being on track, but low-income countries would need to increase their daily rate of vaccination by nearly 19 times to meet the same goal. So it just speaks to this growing gap, not just the existing gap, but the growing gap between countries of different incomes. If we all look at region, it's a similar story, as you might imagine. The region that's most vaccinated at this point, it has the percent of population that have received at least one dose is highest in the European region and lowest in the African region, which of course is where many of the lower income countries are. So 2% of the African region as a whole has had access to at least one dose of a COVID-19 vaccine. Reflecting the chart that Nahid also showed, the inequalities by country shown on this chart, also from our World in Data, demonstrate what I've just described. So, under 1% in many of the countries in Africa, whereas countries in North America and Europe have well over 50 and approaching 80% in some cases, and even exceeding that in some places. So just a picture of inequality. And if I think of the pool of vaccines and vaccinations as has been dammed and limited to a certain set of countries, whereas there's a whole region of the world that's parched and looking for that access to those resources. So turning to COVAX, and as Nahid talked about, COVAX is an important mechanism by which many low-income countries have access to vaccines, both now and going forward. But as she noted, there are a number of issues that have limited COVAX reach up until now. For example, the current projection from COVAX itself, and they released these intermittently, this one's from last week, looking at the projected number of doses that is likely to be provided to the African region, is on the order of 55 million doses provided through July. And, almost half of that is made up of donations rather than supply that has been purchased and distributed by COVAX itself. And that it's going to take many months for the access in the African region through COVAX to scale up to anything like the scale that's needed. And just for comparison, over here on the left-hand side, the total number of doses that have been delivered in the US to date is around 400 million. And so the whole African region won't get close to that number, even if these projections hold, and we don't know for sure they will, until the end of this year. Another mark of the significant gap that we have. So one shorter term approach to addressing this gap is to provide donations, and a number of pledges have been made by high income countries. The G7 in particular has committed to donating 1 billion doses of their COVID vaccine supply. By the middle of next year, the US government has pledged to purchase 500 million doses of the Pfizer vaccine by mid-22 and provide those primarily through COVAX. And the UK and EU nations as well, large numbers of pledges. But the issue here is that, the need is immediate and many of these pledges look out later this year or into next year. And so the actual number of doses that have been provided, donated and provided has been quite limited so far. Maybe the UNICEF estimates it's about 100 million donated vaccine doses actually delivered to countries so far. So that's a tiny portion, of course, of what's needed. So just to be clear, the messages here, if it hasn't already, been drilled into your head, is that large growing gaps in global vaccine access and progress, particularly with low-income countries and African countries being left further and further behind, is the state of global vaccinations right now. COVAX can help address the issue, but supply constraints and a number of other issues has limited its ability to distribute large numbers of doses to countries most in need, and that the donation of doses from high-income countries has been limited so far, and most of the pledges are expected later this year or into 2022, despite the fact that, as Nahid pointed out, many are sitting on significant stockpiles that are only growing over time. And so that's one potential area of interest for addressing this gap in the near term. So I'll leave it there, and thanks.
Thanks so much. Thanks a lot, Josh. And then finally, I want to turn over to Usoka Fala, and I look forward to this presentation.
We know we've seen the data, but we want to add face to the situation in Africa. Where we stand today, we are at a critical juncture, and I would try to convince you with a real life story that the disparity is affecting the ordinary people in Africa and other parts of the world. Next slide, please. Then Grensler made this statement, and it sort of reflects the true reality of Africa. We don't have enough capacity to produce oxygen, and we don't have enough vaccines. That's a perfect storm for mass fatality. People are dying every day in Africa. People are dying every day in Africa because we don't have to provide vaccines, and we lack oxygen. And so we stand in a situation where I will convince you in the next couple of slides that the reality of the lack of access and inequity affects the ordinary person. Next slide, please. So I'll share these with you guys because, for a long time on social media, we use it to celebrate one another, to recognize people. But for us in Liberia today, the social media only shows death every single day. What is even more troubling is that these deaths are happening in family. These are 3 members of a single family, all dead in the space of 2 weeks. These are brothers that have died. And so death is happening every morning. You turn on social media, Instead of having peace and happiness, you see death. I've seen a lot of death. I was with Ebola. I saw people decimated, family died. But the reminder every morning that someone is dying, all because we can have access to vaccines. Next slide. I had a friend go to one of the cemetery in Morovia to do a video recording of the cemetery just to record the number of fresh graves that were dug on a Thursday for burial on a Saturday. And these are all fresh graves you see. And as we talk to families on this grave, they say to us, since Ebola, they have not seen such a rapid production of grave site for burial. These graves were meant to bury people just within 3 days. Why? Because Africa cannot produce enough oxygen. Why? Because we don't have access to vaccines. And what does it translate to? Families are dying every day. Next slide. Now, what is the reality that we see on the cemetery? People are dying. Families are being wiped out from the face of the earth. WHO has just reported that in Africa alone, in week by week, we have seen 43% increase in COVID death. These deaths are only in 5 countries. I was reading an article this morning that stated that they think the death in Libya from COVID may be in the millions. So Africa records 299 deaths every single day. But even what is troubling is at one point in time, our case fatality rate was low, but today Africa leads the world in the number of persons that die for every 100 persons. About 3 persons die in Africa compared to 2 persons in the world. And we do know that the reduction in the death among the developed countries can be attributed to the vaccines. The WHO representative for Africa said, all of the hospitals in Africa are reaching breaking point. The reality is known in Liberia, many patients will die before hospitals. There are no beds. Next slide. But one of the reasons why are we seeing this? Like I said before, the only way we can solve this problem in the testimony from the global community is that vaccine is the way to overcome all of these struggling health systems. We can fix them now. Let me give you the numbers. In Africa alone, of the 3.5 billion people vaccinated, only 52 million Africans have been vaccinated. No wonder why we see increased death on our Facebook, increased grave coming up every day. Only 1.5% of the 1.3 billion people on the continent have received full vaccine compared to 50% from the high-income countries. No wonder why we see the death as a daily occurrences in families. Next slide. Okay, assuming that we will not have vaccine, and some of us projected this a long time, we said in a long time that Africa was unprepared to manage severe cases. This disease is a disease of oxygen. Let me give you an illustration, few illustrations. Uganda has the ability to produce 3,000 cylinders per day. However, the demand from COVID is around 25,000 cylinders per day. In terms of vaccine, out of a population of 44 million, only 2% have received the vaccine. In Ghana, we get report that all of the ICUs are getting overwhelmed. Why? Out of 30.4 million people, only 4.2% have been vaccinated. Next slide. So we have a double-edged reality that we are facing in Africa. We lack the ability to save those that get infected. And the best way to protect the world is the vaccine, but we don't have the vaccine. My own country, Liberia, out of a country of 4.9 million, we have a 1% vaccine coverage. The death toll are growing every day. We do know in Liberia that the deaths are more than what we are reporting because there are cumulative deaths happening in families and homes. In Sierra Leone, 1.4% out of 7.8 million people. Sierra Leone has only 2 oxygen plants for a population of 7 million persons, 8 million persons, and you see the reality of the cases and the death. I show this photo to illustrate the challenge that we face. What you see around here in Liberia is an oxygen regulator. It costs $57 at Amazon. Hundreds of oxygen tanks are sitting in Liberia, and patients are dying from the lack of oxygen. We had to make an appeal to the US, Friends of Liberia, the University of Kentucky to procure these for $57 and DHL them to Liberia. We predicted this, that without vaccine, the health system in Africa would not be able to save those that got infected. Next slide. No wonder why the realities are out. That all those who are severely sick from COVID-19 are dying at a higher rate in Africa than all other parts of the world. Nearly half of those who are infected will not survive in Africa compared to the rest of the world. Why? Africa lacks the ability to provide adequate vaccine for these people so much. And the painful part is that they will gasp for air and they will slowly die because there are not enough vaccine, enough oxygen for them. Next slide. This is a photo I want to show that is heart-wrenching. People have realized this is Liberia. People are online. They have gone since early morning hours to wait for vaccines, but there are no vaccine to be around. And if any one of these people get infected, we are very convinced that 1 in 2 of them will die. Half of these people will die because there are not enough vaccines. The evidences are there from the US, from Israel, from Europe, and now in Ghana, that those who are currently dying in Ghana are those who have not been vaccinated. The document have shown it in many countries that being vaccinated reduces severity of disease, it reduces death. But for many of these people who are online waiting for vaccines, if they get infected, they are going to die. This is this reality we face today. It is established that there is less saver. In the midst of this extreme sea of neglect, others are bathing in an ocean of surplus vaccines and can make choices which vaccine they would take. When in Africa, we are gasping for air for a single dose of vaccines. Next slide. So finally, I've just shown you that Africa faces the perfect storm for mass fatality. These are not numbers, these are families. These are fathers and mothers. Many orphans are going to be left after this. There will be many widows left because we can't give them the oxygen and we are not having the ability to prevent them from dying from the vaccine. In closing, I will leave with these messages of us. It is our moral ethical duty as humanity to provide for those who can provide, because as human, we are intertwined. We all live, we all die, and we all feel pain, no matter our geography and our economic condition. If we cannot provide at least 60% of this surplus vaccine, people are going to gasp for air every day and are going to die. Fathers are going to gasp for air and they are going to die. The other part of it is that we are humanity, our humanity is intertwined. The neglected spot of today can become the trouble spot for tomorrow. If Africa is neglected, variant could spring up and defeat every effort that developed countries are making for vaccines. We see that happen in India, in Brazil, and South Africa. The countries that do not have enough vaccine. Solution, we ask for support to COVAX. What COVAX promise is a fighting chance for Africa to at least immunize the vulnerable population. We advocate for RP and technology transfer, like my colleague said. We are advocating for tier pricing, some form to be done. That's why in Africa, we commend the initiative by President Biden to support COVAX and support countries. You've seen faces, you've seen fresh graves. You've seen that we cannot provide adequate oxygen. People are dying from gasping for air. The best way to help Africa today is to do everything in our power to increase the ability to have equity access, increase access to vaccine, because we are one humanity, we all feed the same, we all live the same, and we all die. Thank you very much.
Thank you, Dr. Fala. That was it's pretty terrible to hear. So I want to move on to the Q&As. And I guess, watching Dr. Fala's presentation, something that just is on my mind is that final slide that Dr. Badelia showed. So one thing I can say is in the US, we've got a massive surplus of vaccines that are going unused very, very quickly, that some are set to expire soon. So to hear that we'll have millions of doses expiring because they won't be used here, and yet there's people in Liberia whose lives could be saved for this. I guess I would love to just know more, maybe Nahid or Josh, you could speak to what's stopping us from exporting these doses.
Yeah, I can start, and I'd love to have Josh's perspective as well as Dr. Fallis. The initial conversation had been that, the way that the agreements had been set up between the Trump administration, the Operation Warp Speed, as well as the manufacturers, the vaccine manufacturers, there's a limit to exports. I kind of think that, that's also a political will issue. When you look at, this is not business as usual. This is not, we're not talking about the fact that, oh, well, this could wait until we figure out the legalities of this. We're really talking about the crisis that, Dr. Bell is talking about is getting repeated in tons of other countries. Indonesia is seeing a surge right now. They're seeing similar pictures. India saw a surge last month. It's seeing a similar picture. I lost family members in India while I was trying to convince patients here in my clinics to take vaccines. I had vulnerable members of my extended family who could not get access to vaccine, and I lost about 3 members of my extended family in India. Losses are being sustained at an exponential rate. And so those initial sort of agreements need to be really re-looked at, and potential donations need to be made of that surplus today. In my mind, it is a political will issue as much as any of those agreements. So I'll have Josh comment on that as well.
Yeah, I don't have too much more to add other than to say that, without knowing all the legal details of these agreements, it does seem like this is where there's a will, there's a way kind of opportunity. After all, the AstraZeneca vaccines that the US purchased, some of those have been able to be donated. And you would assume that the similar types of clauses existed around the purchase of those vaccines. But with that said, if there was enough push on this, we could certainly see an increased number of vaccine doses. Now, part of the reason is that these doses have been distributed around the US and are sitting in different locations. And so there's a logistical issue involved in getting all of them. But again, these are solvable issues, it seems to me. And certainly a growing stockpile just seems to scream out, something more needs to be done that's being done already.
Thanks a lot. Okay, so I think I can kind of combine 2 questions here. One is from Jim Balls, and he asks, what vaccines are the best for protection against the Delta variant? I think I've seen that, Pfizer and Moderna surely protect against the variants. And also the follow-up to that is it a good reason to get these vaccines to Africa? And then maybe Musoko, maybe you can comment on this part of it. Is sort of some of the underdevelopment in Liberia or other parts of Africa, is that a big barrier to the need to keep these vaccines very cold? Maybe we'll start with you, Dr. Falla.
I was involved in the Ebola vaccines, the development, the phase 2 clinical trial for the Ebola vaccine are one of those involved. And we have infrastructure in place for minus 80-degree temperature when we move the Ebola vaccines in country. So and many of these countries, like Sierra Leone and West Africa, that were involved. So we know that some of the countries have, that's one. So there's always a possibility with the right infrastructure to have it done because we're able to move that. The second point is that at least on COVAX, some of the studies have shown that 60 to 80% protection against the Delta strain. Even if we can get the COVAX, the COVAX we're using in Ghana, to start with the AstraZeneca, we know it protects 60 to 70% is better than zero. A friend wrote me a few days ago and said, Dr. Fala, I'm scary. I took the first dose of the vaccine. I'm about to go and take the second dose, but there's none available. I'm talking about the AstraZeneca that came through COVAX. We can't get a second dose, and there's no hope that the second dose will come. So we do know there are evidence for AstraZeneca, for the Delta, some protection in the Pfizer infrastructure are in place for those 2 vaccines. But the key, we need to get something at minimum, AstraZeneca or Pfizer.
Great, that makes sense. So, another kind of a question that I have, and I think some people in our audience do too. So it sounds like from the slides we've seen that COVAX is limited, sort of this donation model is limited. Also, most of the vaccines slated to be manufactured this year have already been bought, as Josh said. The vast majority have been bought by the US, by China, by Western Europe. So to me, that sounds like we need to ramp up the supply. And so, Josh, I'm wondering, what can the Biden administration do to sort of push for more vaccines, to make more vaccines? What can be done about that? I mean, are there, clearly there are generic vaccine manufacturers around the world. Is there anything that can be done to sort of persuade these companies to work with these generic manufacturers so that we get more vaccines that could perhaps be sold at a lower cost?
Yeah, certainly there are a number of steps that could be taken, and some of them are, in nearer term. Some of them would be a longer term, solution. But essentially, the immediate term would be to provide the doses that have already been stockpiled and through a donation model. But if we're talking about expanding the production of vaccines, there are a number of things. So one is to identify and help make the connections between potential producers and the actual producers, the current producers and IP, the intellectual property holders, patent holders of the vaccines, to get more sites producing. There are a lot of things that go into making a site produce, other than just the technical know-how. There needs to be supply, there needs to be, make sure that all the ingredients are in place, the regulatory requirements, a lot of those that Naheed talked about in her comments. So that's a lot of legwork that certainly the U.S. government, others could be helping with, and to some extent they are. And one of the priorities under the U.S. COVID-19 Global Response and Recovery Framework that was released just a few weeks ago regarding global vaccine access was to accelerate supply and manufacturing of COVID vaccines and expand, particularly this fill finish. The announcement that Pfizer made today, for example, with South Africa of finishing the vaccine production process and putting it into vials ready to use. Those are the pieces where the U.S. government has really started to focus. But one can imagine more ambitious, longer term efforts to really scale up manufacturing capacity in countries. The US has signaled that they might be interested in doing that. One, because they're supporting the intellectual property waiver, the TRIPS waiver, which might be a leg up for companies that want to invest and support more localized manufacturing capacity. But really, it's going to take a lot more investment, a lot more, maybe, I don't know if arm twisting is the right word, but really starting to bring the parties together to make these, what are currently very voluntary agreements between different companies to work, on a much more rapid basis than we've seen so far. But I don't know if Naheed has more to say on that.
Yeah, I was going to say in the short term, I think the redistribution is the fastest way to try to get these. And the other, I'm just going to retread because I think it's important for emphasis. The other is to continue to lift those exports on raw materials that are required for places that already are producing manufacturing vaccines, like India and I think I saw a comment, India and South Africa and other places, to take the, not necessarily mRNAs, but the the virus vector vaccines that are being produced there, to allow increased doses of those. The third is the finish and fill, is taking those places that already have that minimum capacity for manufacturing, the regulatory aspects already have the physical infrastructure, and actually expanding, allowing them to become sites where you could finish the last step to try to produce increased effort. Again, I think that's going to be limited by the raw material, so that those first steps need to be taken for that last step to be allowable. I do want to say that the other thing that you can help, I think the US can help with, is to actually more fully fund the accelerator, the Access to COVID Tools Accelerator, under which COVAX falls, which is access to medications. Monoclonal antibodies are a dream in most, that most patients don't get recognized in resource limited settings. Most of the patients that you're seeing that are heavily affected in Sub-Saharan Africa, those are not available, right? I mean, if vaccine is one aspect, if we want to help with a mass fatality that Dr. Fala talked about, I think that we can fully fund COVAX, and we can fully fund the ACT Accelerator to allow access to those other tools to help improve survival in those countries.
Great, thanks a lot. That answers one of the questions about what can we do to support COVAX, fully fund it. So let me ask a question from Kripa Shripada. So straightforward question, it seems like, but probably not. How many more vaccines are needed? And then the follow-up to that one is also, let's say we get some, other manufacturers either to produce the vaccines fully or to do fill and finish. About how long will that take to sort of start a new manufacturing process?
Well, I can jump in and others are welcome to. So how many more vaccines are needed kind of depends on what population you want to cover with vaccines. But if we just talk about, you can imagine if the global adult population is the target. I haven't done the calculations, but we're talking, over 10 billion doses just to cover that population. And maybe more. So if you're talking about very specifically the highest, risk populations, say adults over 50 and healthcare workers or those workers in high risk environments, that number might be smaller. But so if we looked at the vaccine production forecast, they're talking about 10 billion doses being provided this year, but the distribution of those 10 billion doses is really the issue. It's so unequal and highly concentrated in certain countries that other countries are left mostly without vaccines. So you need to both increase production, of course, and if they could be localized production, as we just talked about, focus on particular regions where there's little access now, it's one issue, but also a redistribution issue as well. So by the end of 2022, are we likely to have enough vaccines to go around? Yes, but are they going to be used in a way that's equal and able to really address the pandemic where it's mostly causing problems? That is another question altogether. We really need to solve that.
Amy, can I just take one quick question that I think is important? Andrew Heron asked a question in the Q&A, which I think a lot of people are going to be trying to ask, which is, what about boosters, right? Because the Americans are asking, well, if we need boosters, then why are we giving away our doses? The data so far shows that if boosters are needed, it's, and again, what you're looking at in those breakthrough infections where they become severe and have to be hospitalized due to Delta and this answers Catherine McAlpine's question as well. It's really in a smaller portion of the population. It is those that are older than 65, immunocompromised, those that were never able to get the same level of immune activation for the first 2 doses. And that's a much smaller proportion, right? There's no evidence yet, as far as we can tell. And in fact, evidence on the other side that shows that there might be longer lasting immunity for most people who've taken the vaccines. And so right now, I think the impact on our destiny is the distribution so that the continued transmission doesn't occur. So we're not sort of chasing our tail in terms of new variants. It makes more sense from our own health to maybe reserve some boosters for those subpopulations that potentially, in the medium term, may need a booster. But I think in the longer term, actually distributing more widely quickly is how we keep the American population safe as well.
That's great. I see.
Yeah, 2 quick things. Some work studies were done in the UK and in India that shows actually that I think you get 76% with the first dose. And I think India is reconsidering her policy that you can wait up to 16 weeks. And it shows that it increased the immunogenicity after 4 months. So that's clearly established that you have a 4 month, but you have initial, from the primary, you have enough protection. The second thing is that, so it's counterintuitive. If we keep the SS vaccine for the booster, but we have increased cases in other countries, we run the risk of variants, and those variants will compromise any vaccines. So that's the counter. So you keep the vaccine for the booster that may get challenged tomorrow in the case of the Delta. So you got to create a buffer system by the redistribution and vaccinating more persons. That's one. The last portion is that MasterCard Foundation has given Africa CDC $1.3 billion to procure around 50 million doses for Africa. That's equal to only 6%. 50 million doses is 6%. And some calculations have shown that at the current rate, it's going to take off 4.8 years to immunize Africa. So I don't want the current rate, as I things change substantially, it's going to take 4.8 years to immunize Africa and run the risk of all the variants that will affect other countries. Thank you.
Thanks a lot. You know, we're at time. There's a couple of other questions here, sort of about, you know, the need to waive patents. Maybe as one final comment, you know, Dr. Bedelia, do you want to close, and do you want to say anything about, you know, is this the number one thing we should be pushing on? And maybe if you wrap that up in some closing remarks.
Thank you, Amy. It is one of the things we have to do. I mean, I think that was the point of today's presentation, is to say that that is necessary, but it is not sufficient, because it actually, I think that that's a longer term picture that we need to continue to work on. In the short term, you saw the other solutions that we posed, but if we don't waive that, you just heard about Dr. Vola's projection about a 4-year lag time to try to get to the whole population, you know, in the continent of Africa. Like we're going to be looking at this 2 years down the road unless we do something about it. And so even if it takes time, that is the first step. Those waivers are the first step to trying to get those vaccines to what they need to be. But there are many other steps that need to happen. So I would say necessary, but not sufficient, and certainly not for the immediate answer for what's needed.
Great. Well, thanks so much. Thanks to our panelists. Thanks to the listeners. To me, the take-home message is pretty clear. The current pace isn't going to hack it. COVID's going to continue. I worry about seeing the emergence of COVID-22 or COVID-23 if this continues. The good news is there's all of these incredible technologies that it's really stunning, and we've never seen vaccines come out this quickly. And the challenge is just production and distribution. It seems really solvable. So with that, thanks so much for joining. The briefing should be posted soon on Boston University's website. Have a great day. And I think that's it.